You know that feeling? Just drowning in medical information sometimes. All the studies, the big population data.
Oh, absolutely. It's overwhelming.
And then there's the actual person, the patient, right in front of you. How do you connect all that big data to their specific situation? You want the real insights, but quickly.
Exactly. That's the million-dollar question, isn't it? Bridging that gap between the broad research and the individual's lived reality of being sick or staying healthy.
Well, that's what we're getting into today. This isn't just a surface skim. We're going deep, really deep, actually, into a fascinating way of looking at medical education, research, patient care, all coming from Narketpally, India.
Yeah, it's a really unique perspective.
Think of this as your shortcut to getting your head around it.
And we've got some great material to work with. The main source is a paper called Narketpally Syndrome and the Embedding of Contextual Values in Real-Life Patient Pathways. Kind of a mouthful, but lays out the core ideas. And then we've got commentaries chipping in Sternberg et al., Greenhalgh, Ioannidis. They all bring slightly different takes, different angles on this challenge.
Okay, so our mission, basically, is to understand this fresh perspective. How do they actually do it? Merging individual patient stories with the big scientific picture. And, what could that mean for how we think about health, how we learn? Let's dive in. Where should we start?
Well, I think a good starting point is the problem they're trying to solve. Sternberg and his colleagues really zero in on this issue of fragmentation in medicine.
Fragmentation, how so?
They argue that medical education, research, and actually practicing medicine, they often feel like separate worlds. They're not always talking to each other effectively.
Right, working in silos.
Exactly. And the result is this disconnect, this distance. Crucially, a distance from the patients themselves. It's like the puzzle pieces aren't quite fitting together.
And I guess a lot of the science we see, the research, often focuses on really specific things, right? Like one cause, one effect. Reductionism, they call it.
Precisely. And while that's powerful for understanding specific mechanisms, it can sometimes mean we miss the bigger picture. The whole forest for the trees.
Yeah.
Especially when you're trying to grasp someone's complex health journey, like Sternberg and Mercury point out. Focusing too narrowly might obscure how everything is interconnected for that one person.
Okay, so we're missing connections by looking too closely at the parts.
That's the concern. And this is where their idea of a syndromic approach comes in. It's a key concept.
Syndromic.
Yeah.
Okay, where does that word come from? I know syndrome usually means a collection of symptoms.
It does, but the etymology is really interesting. It's from the Greek syndroma.
Syndrome.
Yeah, it means together we highway.
Oh, wow. Together we flow. That's evocative.
Isn't it? And there might even be a link to Sanskrit samodroma, which means something like together tree or together river. Same idea of flowing together, interconnectedness.
So it's about seeing things as linked, flowing together.
That's the core idea. They want us to view healthcare and learning not as these separate buckets, but as a continuous interconnected process, like a river, with lots of tributaries feeding into it.
Okay, I like that river metaphor.
They also use a tree metaphor. The forest canopy, that's like population-based medicine,
Yeah.
big phase 2, phase 3 trials, the stuff that gives us broad data.
The general picture. What works for most people, sort of.
Exactly. Then you have the roots. That represents the individual patient-centered medicine, like phase 1 or phase 4 trials, focusing on specific experiences, individual responses.
Right down to the single patient.
Yeah. And they even mentioned the wood wide web, that underground network of fungi connecting trees.
Oh, yeah, the fungal network.
They use that as a metaphor for how everyone in healthcare is connected. Patients, doctors, researchers, educators, everyone influencing each other.
Okay, so it's all about interconnectedness, the big picture, the individual, the system, all flowing together. How does this actually work in practice, though, in Narketpally?
Right, so Narketpally, this place in India, that's where they've really been putting these ideas into action for the last 7 years or so. It's their living laboratory, in a way.
And they needed tools to make this happen, I imagine.
They did. Two main ones they mentioned are CBBLE, which stands for Case-Based Blended Learning Ecosystem. They pronounce it CABLE.
Cable, okay, like connecting things.
Kind of, yeah. It's the learning environment they built. And the other key tool is PAJR, P-A-J-R, the Patient Journey Record.
Patient journey record. So that sounds like it captures the individual's story.
Exactly that. It's a collaborative platform. Patients, doctors, nurses, they can all contribute to documenting that person's whole illness journey, their experiences.
And the idea is to feed those stories directly back into the learning and the research.
Precisely. It embeds those narratives, those contextual values they talk about, right into this system. It supports that whole syndromic, interconnected view.
Okay, I think I'm starting to see how the pieces fit. But what does it change? Like, how does using CB, Baseli, and PageAR actually affect how doctors think or learn? Did they share any specific examples?
They did, yeah. And they kind of group the insights. Some come more from looking at things from that population level, and others really emerge from digging into those individual PageAR logs.
Okay, let's start with the population view then.
So one really vivid example they use is something they call the wildebeest river crossing value model.
The what? Wildebeest River Crossing. Okay, you have my attention.
Ah, yeah, it's memorable, isn't it? It came up in a journal club. They were discussing a study comparing clopidogrel versus aspirin after a heart procedure, a PCI.
Okay, standard stuff. Antiplatelet drugs.
Right. And the discussion initially, it really got stuck on the relative risk reduction. Drug A reduces the risk by X% compared to drug B.
Yeah, that's always the headline grabber, right? 20% lower risk.
Exactly. But one person in the group pushed them to think about the absolute risk reduction, the actual number of people helped.
Ah, the difference between percentage points and actual lives changed.
Precisely. And they use this analogy. Imagine thousands of wildebeest crossing a river full of crocodiles. Maybe one crossing spot has a 10% lower chance of getting eaten compared to another.
Okay.
But if only, say, 100 wildebeest get eaten overall at the bad spot and 90 get eaten at the better spot, the relative difference is 10%, but the absolute difference is only 10 wildebeest saved out of thousands crossing.
Right. The percentage sounds big, but the actual number saved might be tiny.
That was exactly the point with the drug study. The relative benefit looked impressive, but the absolute number of patients who actually avoided a bad outcome because they got that specific drug was, well, pretty small.
So the big takeaway is don't just look at the relative numbers. Dig deeper for the absolute benefit.
Yes, always ask, what does this percentage actually mean for an individual patient sitting in front of me? But what was really interesting, they found it surprisingly hard to shift the group's focus. People kept defaulting back to the relative risk numbers. It really shows how ingrained that way of thinking can be.
Wow. That says a lot about how we interpret data. Any other population-level insights?
Well, building on that, they floated a hypothesis. They wondered if medical education systems that rely heavily on rote memorization, just memorizing facts without deep critical thinking, if maybe that makes doctors down the line a bit more likely to just accept interpretations of trial data that, shall we say, favor the drug companies, especially interpretations that shout about relative benefits.
Ooh, that's provocative. Connecting teaching style to potential bias in interpreting research later on.
It is. It makes you think about how we should be training doctors to really critically appraise the evidence, not just memorize it.
Definitely. Okay, so that's the population side. What about the insights from the individual patient journeys from PageAR?
Right. This is where you see the power of context. They give an outpatient example, a 55-year-old woman presenting with anxiety. But when they dug deeper, using PageAR, it turned out her anxiety was tightly linked to her daughter having panic attacks.
Ah, family connection.
And the daughter's panic attacks.
Yeah.
They seemed related to the fact that a neighbor's child was terminally ill.
Wow. So her anxiety wasn't just her anxiety, it was part of this whole web of emotional distress involving her daughter, the neighbor.
Exactly, it's this ripple effect. And the key insight was you couldn't effectively address her anxiety without understanding and acknowledging that whole interconnected picture. Treating her in isolation just wouldn't work.
That really drives home how much our social and emotional context matters for health. Powerful example. Was there an inpatient one too? Something about an invisible pillow?
Yes. This one is quite striking. It involved a 74-year-old man who was admitted in a coma.
Okay.
And the team noticed something really unusual. His head wasn't resting on the bed or the pillow. It was sort of suspended in the air, slightly raised off the bed.
Weird.
Yeah. So they called it the Narketpally ligamental invisible pillow sign.
Ligamental, meaning related to ligaments, not psychological.
That was their hypothesis. They thought it might be due to ossification hardening of a specific ligament in his neck. And they linked this potentially to the high levels of fluoride in the water in that region, endemic fluorosis, which can affect bones and ligaments.
Okay, so a physical cause related to the local environment.
Right. And they deliberately contrasted this with the known psychological invisible pillow syndrome, which you sometimes see in catatonia, psychiatric state.
So the same outward sign, potentially, but from completely different causes. One physical, maybe environmental, the other psychological.
Exactly. It's a fantastic illustration of diagnostic complexity.
Mm,
Things aren't always what they seem.
definitely. And what happened to the patient?
Well, here's the other key point. Despite all this initial uncertainty, the diagnostic puzzle, he actually recovered unexpectedly. Yeah. And the learning outcome they drew from this was profound. Illness can be incredibly complex. It can even seem chaotic, but positive outcomes can still happen even when we don't have everything figured out. It's a lesson in humility and maybe hope.
That's a really important message for healthcare, isn't it? Embracing uncertainty sometimes. Okay, let's circle back to the name itself, Narketpally syndrome. What exactly is it, according to them?
Well, initially, if you were thinking in the old traditional medical way, you might hear Narketpally syndrome and think about those physical signs, like the potential skeletal issues from fluorosis may be seen in that area.
Right, like a geographically specific set of symptoms. They mention old studies finding things like that there.
They did, referencing research from way back in the 1930s and 50s. So, yes, that's one possible, more traditional understanding, a collection of symptoms linked to a place.
But they're proposing something different.
Absolutely, they're redefining it. They argue that Narketpally syndrome should now be seen as a unique kind of syndrome, a medical education and research syndrome.
Okay, unpack that. A syndrome of education and research.
Yeah, it describes this whole approach, this globally aware, patient-centered way of learning about medicine, which is ultimately aimed at improving the actual caring that happens locally.
So the syndrome isn't the illness, it's the method, the philosophy of practice and learning they've developed there.
Precisely. It comes back to that together we flow idea. It's an approach, a way of working and thinking. And they suggest this syndrome, this approach, probably isn't only in Narketpally.
Right, it could be happening elsewhere too.
Could be, yeah. Narketpally is just where they've really nurtured it, studied it, and given it a name, you could say.
That makes much more sense. It's a philosophy, not just a local disease pattern.
Yeah.
How does technology play into enabling this philosophy? They mentioned Web 0.0 to 3.0.
Technology is definitely a key piece. They see it as evolving. Web 0.0 might be static information. 3.0 is more interactive, intelligent. They talk about AI, artificial intelligence, but frame it as asynchronous intelligence.
Asynchronous intelligence. What do they mean by that?
Well, think of it as intelligence that works alongside us, but not necessarily in real-time lockstep. AI can process huge amounts of complex patient data from PAGR, for instance, finding patterns over time that a human might miss in the moment.
Okay, so AI as a tool to help us make sense of all that complex real-life data.
Exactly. And they stress how important it is to structure that messy, real-world data effectively for learning, making it useful. They connect it to Bloom's taxonomy, moving learners from just remembering facts to higher levels, like analyzing and evaluating complex situations.
So using tech to support deeper learning from real cases.
Right. And they use specific frameworks for this learning process, things like critical realist pedagogy.
Whoa, okay, big words. Quick translation.
Yeah. Critical realism basically means trying to understand the real, underlying mechanisms causing things, not just surface appearances. Pedagogy means self-determined learning. The learner is in the driver's seat. So learners actively investigating the real complexities themselves.
Okay, active, deep investigation by the learner. And the other one?
UDLCO's user-driven learning community ontologies. That's essentially about the learning community itself, collectively building shared ways to organize and understand the knowledge they're generating together, like building a shared map of understanding.
Got it. So frameworks for active collective sense-making. And how does AI specifically help with that?
They talk about using AI-driven case-based reasoning engines, CBR. These systems can learn from all the past patient trajectories stored in PAGR.
Learning from experience, but on a massive scale.
Exactly. By analyzing thousands of real journeys, the AI might spot subtle patterns, maybe predict potential issues earlier, or suggest more personalized approaches for new patients who've seen similar. It's about being more proactive.
That sounds potentially very powerful, using past experiences to inform future care.
Yeah, and they link this to Joachim Sternberg's ideas too, using things like dynamic modeling and complexity theory, looking for those evolving cause and effect pathways in complex patient data over time.
Not just static snapshots.
Right. Mentioning tools like dynamic Bayesian networks, multi-agent systems. Even work like Dr. van der Schaar's with Temper AI, which is all about analyzing data that changes over time in healthcare.
So really sophisticated ways to analyze the flow of a patient's journey?
Exactly. And alongside all this tech, they also flag the need for more transparency and accountability.
How so?
Things like real-time clinical audits, seeing how care is actually being delivered, and making the detailed contextual data behind clinical trials much more accessible so we can see the full picture, not just the summary.
Okay, makes sense. More open data, more accountability. So pulling this all together, what are the big takeaways for how we should be educating doctors and healthcare professionals?
Well, they argue pretty strongly for a shift. Less focus purely on rote memorization of facts,
Which we mentioned earlier.
right? And much more emphasis on developing critical appraisal skills. Really teaching students how to dissect a study, understand its design, spot potential biases, interpret the data thoughtfully, especially the difference between relative and absolute effects.
Learning to be critical consumers of information, not just sponges.
Exactly. And they champion using real patient data, like from PADGR, in case-based learning. It provides so much more richness and context than simplified artificial case studies.
Makes learning more relevant, I'd imagine.
Definitely. And finally, they stress the need for advocacy training, empowering clinicians and patients too to speak up, ask questions, and push for care that is truly ethical and patient-centered.
So it's a call for more critical thinking, more real-world context, and more empowerment in medical education.
That sums it up nicely. This whole Narketpally syndrome, as they frame it, it's really about moving towards a much more integrated, context-aware way of doing things across the board. Education, research, practice,
Connecting the dots between the individual story and the big data, using technology wisely.
and using that human connection too.
Right.
It's about recognizing that health is complex, it's dynamic. Simple A causes B thinking often just doesn't cut it for an individual's journey.
Yeah, moving beyond the simple explanations to embrace that complexity.
Embracing that together we flow idea. Understanding how weaving together those individual narratives with the broader data landscape can genuinely change how we understand health and how we learn about it.
This has been fascinating, really unpacking this different approach. It certainly gives you a lot to think about regarding how we handle medical knowledge. And for you listening, maybe think about how these ideas, interconnectedness, blending individual stories with bigger data, might apply in your world, whatever that is.
Yeah, maybe digging into concepts like critical realism or heutagogy or case-based reasoning could spark some new ideas.
Absolutely. There's always more beneath the surface when you take a deep dive.